Hey, I'm Dr. Joe Niamtu, LoveThatFace.com. Welcome. We're going to do a little lecture here that's probably about an hour long. And basically, it's understanding facial aging, causes, effects, and solutions. I'm going to go through some of the causes of facial aging and explain how we age. And then I'm going to detail various non-surgical and surgical treatments. So sit back and enjoy. In terms of disclosures, I have 6 textbooks in print. I'm very involved with um, teaching, publishing, and I'm a surgeon, a teacher, and an author. I teach a live cosmetic facial surgery course at my office once a year, and I have an online for purchase video series that's available on the internet that details all of my procedures in live narrated surgery. My name is Joe Niamtu, and I'm a board certified oral and maxillofacial surgeon. I'm also certified by the American Board of Facial Cosmetic Surgery. I'm in private practice in Richmond, Virginia, period. I practiced full scope oral and maxillofacial surgery for about 15 years, and I limited my practice to cosmetic facial surgery in 2004. I performed over 1,700 facelifts, over 6,500 cosmetic eyelid procedures, and a ton of other things. Cosmetic facial surgery is my passion. I have 6 textbooks in print, and I've published hundreds of articles on cosmetic facial surgery. And I guess I'm kind of a nerd because it's my job and my hobby and my passion. You can look at what I do at lovethatface.com. I'm going to cover a lot of territory in this lecture, and I'm going to be showing actual surgical videos and patient pictures. So these are HIPAA protected, and please do not photograph, video, distribute, or reproduce this in any form, or you're going to get me in trouble. Once again, I've put a lot of work into this for your benefit, so please enjoy it as you would if you went to the theater and watched a movie. Today we're going to talk a little bit about the biology of facial aging and the visible signs, some of the contributing factors, some of the preventive measures, and for sure, non-surgical and surgical intervention. This is a very busy picture, but the right side shows the visible aging changes that we see as we celebrate birthdays, and on the right side of the picture, or the patient's left, you see more of the physiologic or anatomic reasons why these fat pads shift, bone resorbs, skin changes. So again, I could spend the next hour just on this particular picture. Beauty is youth, and youth is beauty, and all creatures age and have a lifespan. And it is an amazing phenomenon that people have been trying to avoid since recorded history. Even if you're a queen and have all the benefits and wealth and care in the world, you're still going to age, as you can see the pictures throughout the life of Queen Elizabeth. This is a very famous picture that appeared on the cover of National Geographic several decades ago, showing the piercing eyes and the beauty of this young lady. And they went back sometime several decades later and found this person, and you can see the harshness of aging changes that we all will face if we live to have birthdays. So let's talk about some very basics of facial aging. When we're young, our face is tapered at the bottom like a upside down egg, and all our youth and volume is in the midface, and our jawline is tapered. As we age, it's the opposite, becomes like a upright egg where our face becomes squared off and everything droops, bags, and sags and collects in the lower part of our face. This picture is probably at least a decade old, and it shows three generations of males in a single family, my family, and looking at eyelid changes and changes in the malar fat pad and losing that tapered youthful jawline and ending up with a more squared jawline that I have. And my father, who was in his 80s in this picture, uh, late 80s probably, and you can see the advanced aging changes. We're going to discuss the biology of facial aging. So, aging is a contribution of intrinsic factors. These are things that we can't control. Genetic influences, what we got from our parents, hormonal changes, and collagen and elastin production in our skin. So, although we can influence these, we can't avoid or control them. Extrinsic aging factors are under our control, and these include excessive sun exposure, which is really damaging to our skin, pollution effects from our environment, and lifestyle choices such as smoking, diet, hydration, and of course, sun exposure all affect our aging, as you know. So the skin undergoes a lot of changes as we age, especially with actinic or sun damage. We have epidermal thinning. We lose our subcutaneous fat, which contributes to sagging. We have changes in the blood supply and color and temperature regulation of the skin. If you look at histologic and clinical aging changes, when you look at the histology of youthful skin on the left micrograph, you can see the normal epidermis and dermis. And if you look at the picture on the histology picture on the right side, the rampant aging changes. And if you look at the patient here, this is just somebody who has really severe sun damage and probably harsh lifestyle factors and probably also poor heredity. So wrinkles and fine lines, we start to see these even in our third decade. Skin elasticity wanes and the skin becomes less supple and bruises easier. And any skin around joints or facial mimetic muscles will develop lines sooner and deeper because of the continuous animation and movement. Loss of skin elasticity and volume. This is a natural aging process, and it just happens. We really can't control it. And again, avoiding some of these extrinsic factors can really help this. I know this is getting boring, but hold on to your seats because we've got some good stuff coming up. We have changes in our texture of our skin. Our smooth baby butt skin becomes rough. We get pigmentation changes where we have hypopigmentation, and these are influenced by intrinsic and extrinsic factors. Okay, so here's a picture of a truck driver who drove a truck for decades, and you can see his left side is much more aged and damaged from sunlight come from the driver's window than the other side. So what we do to our skin is directly proportional to how we age, and how we take care of our skin is directly proportional. The osseous remodeling of the bony skeleton also significantly impacts facial aging. And our skull shrinks with age, and these arrows indicate the vectors of change. And basically, we lose bone structure uh, around our skull, around our face, our mandible, in our teeth. And when you lose this bone structure, you also have associated soft tissue changes as well. So when we have these osseous changes, we lose vertical dimension as we lose tooth structure, not only occlusally but interproximally, and we have overclosure. And once again, we have wrinkles around the mouth from continual animation, and we get jowl formation on our lower face because of fat accumulation and descent of fat pads. So we have a number of fat pads throughout the face. I think these are different in different textbooks, but fullness of these regions gives us a full and youthful face. And when these start to atrophy or to sag, then we get these changes that we see as aging. So when we lose these subcutaneous fat compartments, we go from a full, supple, tight face and go throughout these changes where we have the bony changes we described, the skin changes, pigmentation, and wrinkles. So this is the cycle of life. We also have increased fat deposition. On the left is a typical aging patient with fat deposition of her lower eyelids, sagging cheeks, increased jowl formation, subcutaneous fat in the submental region, and excess skin. On the right is a Hollywood fat suit that actors wear to mimic uh, obesity, and you can see how this corresponds to the face and neck. So jowl formation is a factor of a lot of different changes, which include descent of fat pads, malar fat pad, buccal fat pad, skin drooping, and fat accumulation. So jowl formation and extra neck skin are the things that keep me in business because these are the exact things that a facelift corrects, and we'll show you some actual video here soon. Neck banding, again, as our skin uh, becomes loose and descends, our platysma muscle droops, and we get these neck bands, which are a combination of skin and platysma laxity. During facelift procedure, when we perform platysmoplasty, we tighten this platysma and improve neck bands, as you can see in this picture. So let's talk about contributing factors to accelerated aging. Again, sun exposure and ultraviolet radiation is the big damaging factor. And it's really important to protect our skin and use sunscreen, even at a young age. Children begin the cycle of skin damage early in life. And this not only is an aging situation, but increases melanoma, basal cell carcinoma, and related skin cancers. Lifestyle factors, smoking, diet, sleep is really overlooked. Hydration, everybody knows all of these. And once again, the pollution, which we really don't have time to get into this. I want to talk more about the surgical aspects. Preventive measures in skincare are important. Basically, exercise, diet, sleep, as we already mentioned. Sun protection is important, and all adults really should be on Retin-A, bleaching cream, and sunscreen. Those are three things. Those are really the only things that we sell in my office. Everything else is surgery, but those are important in protecting your skin and maintaining youthful skin. Now let's talk about the exciting stuff, and that's non-surgical and surgical intervention. So we're going to talk about the upper face right now. And for upper facial rejuvenation on younger patients, we're using neurotoxins, Botox, etc. And surgically, we would consider brow and forehead lift, blepharoplasty, which is eye lifts, the upper and lower lids. Non-invasive treatments would be Botox and fillers, which we'll talk more about. And these have become extremely popular, as everybody knows. And they are non-surgical, that's immediate gratification. And I think there were over 18 billion um, dollars last year worldwide in these minimally invasive procedures. So neurotoxin treatment here, I've outlined some of the muscles, and we're injecting the brow depressors, the procerus, the corrugators, and the orbicularis, in this case with Botox. Everybody's familiar with these treatments. The injections are focused on the muscles that cause facial expression and specific muscles for specific treatments. It takes about 3 minutes to do this. It usually kicks in by 2 weeks and usually lasts about 3 months. Here is a before and after picture taken about 2 weeks after glabellar injection in this patient. With Botox, I usually use about 25 units to treat this area or 60 corresponding units of Dysport. Here's a patient treating her frontalis muscles before and 2 weeks after, and you can see she can still raise her brow, although that's a little bit decreased, but she has no forehead wrinkling. So these were really new and exciting treatments at one time, but they are pretty commonplace now. Masseteric hypertrophy. This is something that has become very popular for two reasons. That would be slimming the face cosmetically or to treat TMD, clenching, bruxing, muscle spasm, and related situations. So basically, I make a horizontal line at the zygomatic arch and a vertical line at the anterior border of the masseter. I use the full half-inch needle, full length, and inject in areas of prominence on the masseter muscle. And this is sort of patient directed if they have pain and where the injections are. If you inject more anterior than that vertical line, then you have to worry about over-treatment by treating the rhizoris and buccinator muscles, which will skew the smile. These procedures usually last longer than the cosmetic procedures and can last 4 to 6 months in my experience. I usually use about 20 units on each side. These are Botox units or 60 Dysport units to start patient treatments. Some patients respond to smaller doses. I've used up to 50 units on other patients. Here is a patient before and probably 3 weeks after treating her masseteric hypertrophy. She is clenching in both pictures. This is a very popular procedure on Asian patients who have pretty hypertrophic masseters in many cases and squared faces. And doing this, you can see before 1 month and after a year of several treatments, it has really slimmed this gentleman's face. Now let's talk about brow and forehead lifting, okay? So when the brows droop, this is a sign of aging. Now, some people never had elevated brows. But many people have um, brow drooping with aging, and it just makes them look older. You can see the before and after of my patient here in the picture on the left. And there are several ways to do this. We can do it endoscopically, where we're using small incisions in the hairline, and as you can see in the above picture, and releasing the tissues that tether the brow, as you can see in the lower picture.
Now, what we're going to
And
do
this
is three
is what
tongues,
we call a
and we're going to get
open
our
brow
scissors in
lift.
here and
And in
just
this
spread
situation,
them,
we're
basically.
making
It's just
a
a little
beveled
lip
incision behind the
spread, and this
hairline.
is going to be a really,
And
really
what that
thin
does is allow the hair
beveled
follicles to
plastic.
grow back
So
into the
remember, in the central
incision
part here,
site and camouflage the
no
scar.
neurovascular
So this
bundles.
is
You
a
can go all the way down
subcutaneous
to
dissection.
aortic
It's under the dermis and
and
above the frontalis
laterally.
muscle.
Then
And although it probably looks a little
we'll start
barbaric
our
to you, it's
dissection.
about a
Once we get down
40-minute
in here,
procedure,
this is going to
and
be a
it's
lipo
very
regenerative
effective.
flap. So what we want
We're
is
going
fat
to
on both
dissect
sides of the
all of
brow,
the
like
tissues
this.
over the frontalis,
And
and then we will suspend the brow and cut off the extra skin. So in this type of open brow lift, once you dissect under the skin, at about the level of the eyebrows, you can see the supraorbital and supratrochlear nerves. And that's one advantage of this procedure, where you can see the nerve branches. So this is the dermis, this is the frontalis muscle. So as I told you at the beginning, what we do is to trim the excess skin, and we maintain the same type of bevel. And we want a very beveled incision to make the edges extremely thin when they approximate with the other incision. And this fine line of tissue will allow the hair follicles to grow back. And this is just another type of a brow lift. So here's what that incision looks like at 11 days. And over time, about 8 weeks or so, it really becomes almost invisible. So if you perform this brow lift correctly, the incision heals because of the beveled nature and the hair growing back through, and it's a neat little procedure to elevate the brows. So again, a patient with the same type of brow lift, you can see what it looks like at 1 week on the top picture, at 2 weeks on the bottom, or the middle picture, and at 3 months, and you can see that the incision is pretty much imperceptible. So here's a patient before on the left and 3 months after the open brow lift that I showed you. This is also called a trichophytic or a transfollicular brow lift, and the name trichophytic means that it preserves the hair follicles. But you can see how the patient looks more alert and awake and open after her brow lift. Another patient before and after brow lift. I believe this was an endoscopic brow and forehead lift, and I also did a facelift on this patient. And once again, it makes her upper face look more awake, alert, and open. Another patient, this was a brow lift and upper eyelids, as well as lower lid laser resurfacing. And you can see how it just opens the patient up. The upper face is very important in how we look and feel, and if we look old or tired. And if you look at the patient's hairline in the two pictures, you can see that that scar is blended in very nicely. Another patient, this was facelift, upper eyelids, and um, the open brow lift that I showed you. So let's look at a couple things. First of all, let's look at her upper face. She just looks younger and more awake. And obviously her lower face looks better because I performed a facelift. So that improved her jowls and her neck and her jawline also. But if you go back to her eyes, we've lasered around her eyes to improve the wrinkles and the crow's feet. Her brows are higher. And then if you look at her hairline, once again, on the right side, the postoperative picture, it's pretty much imperceptible. All right, now we're going to shift gears and talk about eyelid surgery, which is called blepharoplasty. So as we age, we get fullness in the upper lid where we have excess skin that touches the lashes in many cases, and we have extra fat that takes away the definition of the upper eyelid. In the lower lid, we have herniated fat that gives us these fat bags and makes us look older and tired. The picture on the right is a mother and daughter showing that this can be hereditary, and actually some very young people can have this type of situation. So in the blepharoplasty procedure, I'm using a CO2 laser and I'm making an incision on the skin. This is speeded up a little bit, just to shorten the time. And you notice that when you incise the skin with a laser, there's no bleeding because it coagulates it. So it's very helpful. So we're peeling the epidermis and dermis away from the orbiculus oculi muscle, and the pink area you see under this is the muscle. We don't always excise muscle. In this case, there was a lot of redundancy, and I did excise a small area, several millimeters of the orbicularis oculi muscle. And then under the orbicularis oculi, if you remember your facial anatomy, is the orbital septum. And beneath the orbital septum are the two fat pads in the upper lid. So we don't always reduce fat in the upper lid, but frequently the nasal fat pad is full, and we will reduce this to better define the upper lid and rejuvenate this and make a younger looking eyelid instead of the fat bulges that are present with aging. Once again, you see that using the laser produces no bleeding, which means faster healing, less pain, less bruising. And remember, this video is accelerated, speeded up probably 2 times, 2x. And if there's no bleeding, then we'll close this with a dissolvable suture. And you can use the laser to control any bleeding or shrink tissue. For lower eyelid surgery, we do a transconjunctival approach. So we're making our incision through the conjunctiva of the lower eyelid so there's no scar. I'm using a radio wave microneedle to do this. And these are bipolar forceps to control any bleeding. So we're going to take the conjunctiva at the top of the incision and retract that to hold the incision open. We'll put a retractor in, and now we'll incise the tissue, and there are 3 fat pads in the lower lid. And for people that have bulging fat, we'll reduce this using the bipolar forceps, which is an electrocautery, which prevents bleeding. And having bleeding in the eye can be a serious consequence and cause blindness. So you want to use extreme hemostasis. This is the central fat pad in the lower lid. Once again, there are 3 fat pads, and we're reducing this with the bipolar forceps. And we only take the extra fat. We don't want to make this hollow and make the patient look worse. And then finally, there is a lateral fat pad, and we reduce that similarly. So I performed upper eyelid blepharoplasty on this patient, excuse me, and you can see the skin excess on the upper picture where her excess skin was touching the lashes, and you can see the fullness in her upper lids. On the lower picture, you can see the much more defined orbit and rejuvenated upper lid where you don't have this skin excess and bulges. Here's the same patient in the lateral view, and this illustrates much more the improvement that you see in the upper lid. So you see how we have sculpted her upper lid, removing that extra skin, muscle, and fat, reducing it. And now you can see her pretarsal skin above her lashes, That's a much more youthful look. This patient would have been a great candidate for a brow lift as well, but was not interested. So here's a younger patient that just had premature periorbital aging, and I performed a upper eyelid blepharoplasty, and you can see how his skin on the upper lids was just about touching the lashes before, and how we have now created a more youthful shelf from his lashes to his pretarsal crease. On his lower lids, he had this bulging herniated fat, and it just made him really look old and tired. And I performed the transconjunctival blepharoplasty, as I showed you, from the inside of the eyelid, and again, a more alert and youthful look. Now we'll move down to the mid-face and talk about various rejuvenation in this area, which would include rhinoplasty, or nose surgery, cheek implants, or fat injection or filler injection, surgical cheek lifting procedures, or thread lifting procedures, which is more minimally invasive. So our discussion now goes to injectable facial fillers, and these have become very popular over the last 20 years, and probably many of the people watching this have had filler injection. On the left, there's some of the more common areas that we can inject with fillers. And on the right are the list of FDA-approved hyaluronic acid fillers, which is my filler of choice because it's reversible. And that's important if you inject someone, and if they don't like it, or it doesn't look good, or it migrates, or has a problem, it can be totally reversed almost overnight.
We'll do this with 3 injections. And you can see where the rings crisscross, it kind of blends together. And then I usually pull this and withdraw while I'm injecting. And then we will massage these. And if we need to, we'll go back and fill a little bit in.
And here's some before and after cheek pictures. This patient has actually a facial wasting syndrome, and I had put cheek implants, and it really didn't do enough, and I went back and did numerous filler treatments, and you can see how inflation of a deflated face makes just a huge difference. Again, if you look at the flatness here, and now you see a light reflex here on the after picture. I love doing cheeks.
The dry mucosa, and this is a 1/2 inch needle, so we're going to insert it a 1/2 inch, and then we're going to inject slowly as we withdraw. Now the biggest thing about doing a single cc is you got to split it. Usually you have to split it in some way, shape, or form if you're going to do both lips. So you have to keep your eye on that. And if you're a newbie, just relax a second now. If you're a newbie, your assistant has to keep an eye on that. Now, that's going to be a little lumpy and bumpy till we come back and massage it. Open for me. Okay, here's the dry mucosa. Here's the wet mucosa. There's the wet-dry line. So if I was doing outline, I'd be doing it much more superficially, but doing the plumping the lips for volume, I want to be right in the center of the lip. That's my target, right in the center. And the labial vessels are pretty posterior. Turn this way. And again, needle's 1/2 inch, so we're going to take advantage of that to do the minimum amount of insertions. Now, I always leave a little bit in the syringe on purpose until I see where we're going here. So what we're going to do, can we blot there? What we're going to do is to massage now. We have Vaseline on the lips, and we're going to massage because you always have some little lumps and bumps, and you have to explain that to the patient. And I mean, basically everywhere you insert a needle, you're probably going to have a little lump or bump. Let me see gauze here.
So this is before and after lip filler, and again, with lips like these, it's very easy to treat. Same patient, before and after. Another case, just before and after filler. Nice plump, symmetric lips.
And the patient just has topical on, so if it's uncomfortable, you let me know, okay? Mm-hmm. And a lot of people will do this and say you should only use cannulas and you need to put it on the bone. I rarely inject that deep. The deeper you put the filler, the harder it is to see the augmentation. And what I'm doing here is I'm injecting, so this is Juvederm Voluma, and so far I've used about 1/3 of a syringe. It goes a pretty long way, and I'm a firm believer in moving around the chair. Now, I can see my horizontal and my vertical. And I have to match that over here. And I do a lot of chin implants, so this is a good intermediate thing to give somebody a test drive to see what they'd look like with a chin implant. And I have some patients that don't.
So here's a before and after of filler to the chin. And remember, I referenced horizontal augmentation and vertical augmentation, which you so often need both to have a youthful and well-rounded chin. And now we're going to move on to volume restoration with facial implants. These are silicone implants, and I frequently do cheek and chin implants. The temporal implants are a little less common, and there are also custom implants that can be made from a 3D CT scan and be used really anywhere in the face or other parts of the body. So I'll show you some of the common facial implants. The cheek implants are done through an incision in the unattached mucosa above the canine tooth. It's a subperiosteal dissection, and the implant is placed over the maxilla. There are different sizes and there are different styles. So depending on what type of volume deficiency the patient has or what type of rejuvenation they desire, that's how we decide what type of implant to use. I think it's very important to fixate the implants. I use two 1.8 millimeter titanium screws. A lot of people don't use, especially other specialties, don't use fixation, and the implants can migrate and cause bone loss. On the left is the piriform bone in the B on that picture shows the buttress of the zygoma, and these are areas of thick bone, and that's where I like to place the fixation screws. So here's a patient who has cheek implants and a chin implant, and if you look at the before picture on the left and the after picture on the right, we have really accentuated her facial features, and you can see how the cheek volume really popped her mid-face and how that chin not only increased her profile vertically, but also lengthened her chin horizontally. And this is just a great little procedure because it takes about a half hour to do cheeks or chin, and it's a permanent situation, but it's reversible. if the patient desires a bigger, smaller, or wants the implant removed. Now, you could use fillers here. They're temporary. You could use fat here. It's not reversible. You could do orthognathic surgery, but a lot of people aren't going to go through all of that. So implants can be a great procedure. Here's another patient. I did a facelift and cheek implants and a chin implant. And the chin implant is small, but if you look at the cheeks, that's what really makes her look younger. It carries up her nasolabial folds a little bit. And when I look at this picture, I can see that I also did upper and lower eyelid surgery. So total facial rejuvenation, and it really looks like a different patient. Here's another patient. As I said earlier, facelift is my favorite procedure, and I have done over 1,700 of them, and I frequently do other procedures at the same time. So this patient had a deep plane face and neck lift. She had cheek implants. You can see the huge difference it made in the mid-face. And she had full face laser resurfacing, and you can see how that smoothed her skin. I do believe she had some makeup on here, but the improvements are obvious. Chin implants can be placed through the mouth with an incision in the vestibule and subperiosteal dissection, as shown in the top picture, or they can be placed extraorally through the submental crease or an incision in that area. And this is the blue is actually a try-in. So it's like when you go to a shoe store, you can try on shoes and see which one fits. So we have these try-in implants that we put in there to see if it's the right size and shape for the proper augmentation. Then we remove that and put in the corresponding implant. And once again, just as I showed with the cheek implants, I fixate these implants so they don't move and don't cause bone resorption. If you look at the arrows, you can see the mental neurovascular bundle emerging from the mental foramen, and we have to make sure that the implant does not impinge on that. So different patients have different anatomy. On the top left picture, you can see that there's probably 12 millimeters between the implant and the mental nerve. And on the lower left picture, you can see that the implant is in close approximation, but not touching the mental neurovascular bundle. And here's a patient before and after chin implant. Again, this is about a half-hour procedure. It's permanent but reversible and can make a huge difference in somebody's aesthetics and profile. Another patient, and if you look at the after picture, you can see that we've increased not only her horizontal protrusion, but her vertical protrusion. So we've increased her whole lower facial third, her whole mandibular configuration. This is a patient with that I performed a facelift, cheek implants, and a chin implant. And these implants can really enhance the results of your facelift. They can make a huge difference. And this looks like a totally different patient, but in a very natural way. And that's a very happy patient. Okay, now we're going to talk about my favorite procedure, and that is deep plane face and neck lift. And we don't have time to show every single step of the facelift, but we're going to start out by doing a platysmoplasty from an incision under the chin, and then we're going to make incisions in front of and behind the ear. Then we're going to perform some procedure on the superficial musculoaponeurotic system, which is abbreviated the SMAS. And I'm going to show you not every step of the facelift, but some of the more basic steps.
So we'll begin our subcutaneous dissection using the curved Paget scissor. Our goal is to leave some fat on the dermis, and we're just going to kind of run our scissors through here. Generally, you don't even have to use the cutting motion on most patients, and it helps if your staff stretches the neck, as you can see them doing. And that is my dissection phase. Okay.
So when we get back to our platysmoplasty, as I said, about almost all my facelifts involve platysmoplasty. And usually what we're doing is cutting out a section in the center and then bringing it together with individual, what I call shoestring sutures. It's also called a corset platysmoplasty. Some surgeons actually will do a platysectomy and remove some of the platysma, but generally I prefer the platysmoplasty. So making our facelift incision with a number 15 blade, I make what I call a triarcuate incision. It has 3 arcs to make the incision between the exact junction of the cheek and the ear skin. And then I'm beveling my scalpel to make a transfollicular or trichophytic incision where the hair will grow back in the sideburn. And posteriorly, we're making our incision in the postauricular sulcus and then going around into the hairline once again with an extreme bevel so the hair will grow back through the incision.
Moved this section of SMAS here, and what we're going to do is take this SMAS and pull it in a positive vector. And if we take the retractors out, you can see that this pulls the neck, and it also pulls the jowl, and to a lesser extent the midface. But the neck goes back in, and this is what we're going to pull as an entire unit. And again, look at the neck and look at the jowl. Stop.
And after we reapproximate the SMAS, this tightens the deep structures of the face, and these blue hash marks indicate 2 ovicral sutures that I have placed to keep everything together. And then below the earlobe, you can see further sutures tightening the lateral platysma. So it is very important that we address the facelift in several planes, not just the skin. So this is suturing the SMAS, and it is important now to pull the excess skin in a natural anti-aging vector. And when you see people that look windblown or unnatural, it is because the surgeon either tried to pull the skin in an improper direction, like in the first 2 pictures, instead of the proper posterior lateral vector, as you can see in the far right picture, which is the anti-aging vector.
So we're going to cut here, and this is where you really utilize the curve of your facelift scissors. And if you do this correctly, it'll line up perfectly. So you can see that this will fit in here perfectly. And the important thing is that our hair is confluent. Our hairline here will fall right down with this hairline. There's no notch. So that's how we trim that flap.
And this is our suture closure using dissolvable 4-0, 5-0, and 6-0 sutures. And we try to keep all of the hair-bearing sutures within the hairline, so that camouflages the incision. And the anterior, preauricular, and postauricular sutures are dissolvable, and they leave a virtually imperceptible scar after the procedure. And here is a patient before and probably 1 week after deep plane face and neck lift. So she still has some bruising and some laser on her lower eyelids, but you can see the incredible difference that this makes with this procedure. Another patient that I did recently, this is before and 24 hours after deep plane face and neck lift. And once again, managing a tremendous amount of skin excess that is going to restore her profile. we will perform a laser resurfacing for the wrinkles and pigmentation about 3 months after she heals from this procedure. Another patient, and again, these are, I see over half of my patients are from out of town, so a lot of times I don't have pictures past a week or 2 weeks when the patients go home, although some patients are nice enough to send pictures after their recovery. But this is before and probably a week after deep plane face and neck lift with a chin implant, and you can see the incredible change here in her profile because of the facelift, removing extra fat and muscle and trimming her submandibular glands. So this is definitely a home run procedure. This patient is, I think, a couple days after deep plane face and neck lift, chin implant, and full face laser. Those little dots that you see on her earlobe and on her face are from the CO2 laser. And once again, trimming her submandibular glands, performing a deep neck lift, deep plane facelift, and chin implant just completely changes her profile. And this is going to be an extremely happy patient and happy surgeon. Here's a male patient before and 24 hours. And again, some of these patients just have extreme skin excess. Sometimes it's just heredity and aging, and sometimes it's after massive weight loss. But you can see the incredible change just the day after the facelift. Another patient before and 4 months after deep plane face and neck lift. This is a big guy, about 6'5", and restoring his normal facial and neck balance, and also placing a chin implant. This patient had facelift, upper and lower eyelids, cheek implants, and full face laser. It's an older case of mine, but represents comprehensive facial rejuvenation where we are addressing the upper face, the mid face, the lower face, the facelift, and the skin quality with CO2 laser. So when we're talking about skin treatment, we have various lasers that we can do, microdermabrasion, chemical peels. We'll talk a little bit about this because once we correct the eyelids and the cheeks and the facelift, all of that, if that was an automobile, that's the body work, and we're going to paint the patient, which is the skin resurfacing. And this is an older picture, but cosmetic surgery also involves non-surgical treatments with a lot of various lasers or devices. And my device of choice for resurfacing is the CO2 laser.
So with the traditional laser settings, you are moving the CPG and making a specific pattern, which sometimes shows through on the skin. I like to do this little circular movement, and you can actually just do this, an erratic movement. We kind of call this shake and bake, and I think it gives a better coverage without demarcations, without the lattice marking. And it's fractional, but it's not, because we're filling it in over the areas that we've lasered.
So here's a picture before on the left and after CO2 laser resurfacing, and you can see what an improvement it made on her skin in terms of her skin texture, her wrinkles, and her pigmentation. We didn't do any other procedure except the CO2 laser. Another patient here before and after CO2 laser. I did do her eyelids as well, and once again you can see what it did for the pigment and for the wrinkles. The recovery on this procedure is about 2 weeks. And I really didn't mention recovery on some of these other procedures. Eyelids are about a week. Facelift, the initial recovery is about 2 weeks. And you have improvement over the next several months. Most people get out of their house at about 2 weeks. In another patient that I performed upper and lower eyelid surgery and full face CO2 laser resurfacing, once again, you can see the big improvement of her facial wrinkling and pigmentation. Now, this patient would benefit from a facelift, but not all patients are interested in that procedure. So in this case, we just performed laser resurfacing. So for patients that don't have a lot of skin wrinkling or patients with darker skin types, we will do a chemical peel using trichloroacetic acid in this case. And this is a procedure that is using an acid to burn off the damaged layers of skin as opposed to a light source, which we just showed with a CO2 laser. I can perform this procedure, a chemical peel, on the lightest and the darkest types of skin. It's safe to do that, whereas the laser is more aggressive and can cause permanent lightening or darkening. But with a chemical peel, it's not as aggressive, so it's not for deep wrinkles, it's for fine lines and wrinkles, but it's really good to homogenize the skin, take off the roughness, smooth the skin, improve fine lines and wrinkles. So that's another type of skin resurfacing. All of my patients that I have showed you that are surgical are asleep. They're sedated for the procedure. And here is a before and after. This is my friend Susan Obagi, an esteemed dermatologist who did a chapter in one of my textbooks. And you can see the pigmentary improvement from a single chemical peel. So once again, my name is Dr. Joe Niamtu. I practice cosmetic facial surgery in Richmond, Virginia. I love what I do. I love making people look younger. And I hope that if people that are watching, if you're a doctor of any type, I hope you enjoy your profession like I have. On Sunday night, I'm very excited to get up Monday and go to work. And that is a great gift to love what you do for a living. And finally, we want to always be a student and always be a teacher. Continuing education is important, and you can see I've done a little bit of that over the last 4 decades. And once again, it has been my distinct honor to have the greatest gift of all, and that is your time. I hope you have learned something, and if I can ever answer any questions, my email is niamtu@niamtu.com. Have a great day, and thanks again for your time.